Welcome, everyone. Welcome. Thank you for joining us today. We will be getting started in about a minute or so. We're waiting for folks to trickle in from the waiting room. All right. Okay, so I'm going to go ahead and just give a brief overview. My name is Damilola Jolayemi, and I'm program coordinator at the Center for Behavioral and Addiction Medicine. It does say Center for Behavioral and Addiction Medicine in my name on here, but I'm just going to give a brief overview of the series before we get started. This is a case-based learning collaborative on stimulants. A lot of you have joined us in when we started and launched this in October of 2023. So welcome again. And if you're new, welcome. And I hope that you will have a great learning experience today. These series are held on the first and third Fridays at 12 p.m. to 1 p.m. Pacific time. This series is hosted by the Center for Behavioral and Addiction Medicine in the Department of Family Medicine at UCLA in collaboration with the Los Angeles County Substance Abuse Prevention and Control, SAPC, and the UT Southwestern Clinical Trials Network Big Southwest Node. Next slide, please. So these are the objectives of the series, and we have seen this in all of our correspondence that has gone out, so I wouldn't go over this again. Next slide, please. All right, so just a few housekeeping items. We ask that you use the Q&A for questions and the chat for comments during the lecture. Now, that's fine if you happen to use both, but it'll be helpful to use the Q&A for questions. We also ask for engagement especially during the case discussions. So please feel free to turn on your camera, unmute, raise your virtual hand if you prefer to use that option. And if you do not want to, then you can also use the chat as well for comments and the Q&A for questions. But we really want to have an engaging discussion. So please feel free to, engage just like as if we were in person. For CMEs, we will ensure that you attend the full lecture and complete evaluation that will be sent at the end of the lecture. There's closed captioning and who would like to use that. And we also have archives of previous presentations online, and that will be sent in an email after this session. The next session will be on Friday, February 2nd, same time at 12 p.m. Pacific time. The next slide shows our disclosures for this series. And while I'm doing that, I'm going to go ahead and welcome our moderator for today, who is Dr. Shapta, the chair for this series. Dr. Shapta, go ahead and unmute yourself and welcome our speaker.
Okay. Hi, Dami. It's a real pleasure to be here today. We have Dr. Phillip Coffin here. He is not only a friend, he is one of the biggest and most effective advocates for people with addiction and the needs for their care, as well as some of the concerns that they have as well, including infectious diseases. Phillip is a board certified and practicing internist. He's an infectious disease specialist and addiction medicine specialist. He attended or trained at Brown University, Columbia University, UCSF, and UW. He directs the Center on Substance Use and Health at the San Francisco Department of Public Health, including clinical trials on medications for multiple substance use disorders and interventions for opioid safety, overdose protection, HIV prevention, hepatitis C treatment. One of the things that I really respect about Phillip is that he really is an advocate for our folks. Our folks often have no one who is in their corner, and Phillip always sees the whole person and goes the extra mile within his research and his clinical work to make sure that the health of his patient is foremost and front-centered. So I think it's an incredibly complex and interesting idea about thinking about managing toxicities for people with methamphetamine use disorder. So I'll get out of the way, but I also want to point out that, to be perfectly candid, as he says, he'd rather be kite surfing. So Phillip, I'm turning it over to you.
Yeah. Rather be kite surfing, although my aging injuries may make that less and less common as the years progress. Thank you, Steve. That was really kind. I am excited to talk with you all today. and look forward to an interactive discussion. I will jump right in. So I'm gonna, before we get into sort of the systematic approach that I want to suggest for how to manage methamphetamine use, I want to talk a little bit about how this approach came to be, which is to take a step back and think about what are the toxicities around methamphetamine use that we're trying to address. And so I'm going to start this, and I'd love it if anyone wants to put answers in the chat. What do you think causes death from acute methamphetamine poisoning? Okay, I've got a stroke, heart attack, cardiac arrest, coronary vascular disease, accidental fentanyl use, hyperthermia, self-injury, brain hemorrhage, seizures. I love it. Y'all are doing the work for me. Prolonged toxicity. Yeah. So yeah, that. I'm definitely going to agree with that one. All right. I'm going to keep going here then. So, thank you for being interactive. So when you think about opioid overdose, which is where our overdose construct comes from, opioid overdose opioids cause a reduced drive to breathe. That eventually leads to not breathing or breathing less and less, being non-responsive. That's what lands you in the emergency department or otherwise being managed by your community. And then the cause of death fundamentally is respiratory arrest. Of course, eventually it's cardiac arrest, but it's through the pathway of respiratory arrest. And for stimulants, we're going to go into this a little bit more, but this is the sort of most of the toxicity you see from stimulants falls in this pathway. The main toxicities are cardiovascular and neuropsychiatric. So for cardiovascular, we've got a lot of the things that have already been mentioned, methamphetamine-associated cardiomyopathy being a really key one. And that's a common cause of landing in the emergency room from methamphetamine use. And it's probably the cause of most of the deaths from methamphetamine use. We know that it is way more likely to have a cardiac event or cerebrovascular event with methamphetamine use with a methamphetamine quote overdose than a heroin overdose or an opioid event. But still, most of the deaths that occur are occurring in the community where the medical examiner doesn't have enough information to really describe the mechanism of death. The other category being neuropsychiatric, and I love the self-harm piece here because in addition to psychosis, there's a lot of there's cognitive decline in terms of memory, learning, executive function that occurs with time, and as well as Parkinsonian symptoms and disease that's several times more likely among people who use methamphetamine. And that is, again, probably the most common methamphetamine-related reason to land in the emergency department is agitated delirium, and then second only to is trauma. And we know that people who use amphetamines around the world are far more likely to have these injury-related deaths, both due to unintentional trauma and suicide and homicide than people who aren't using amphetamines. So this neuropsychiatric pathway plays a big role, and we don't count it at all. We're not counting any of these suicide, homicide, or accidental injury deaths as methamphetamine-related deaths. And we have seen deaths really, really skyrocket. But I want to suggest that accidental exposure to fentanyl was another item listed in the chat. I think that's a big one, accidental or intentional. Most of the fentanyl methamphetamine deaths are probably intentional use of fentanyl. Some proportion, we don't know, probably somewhere between 3 and 20% is unintentional exposure to fentanyl among people intending to use methamphetamine. I want to really suggest that this category that's in gray, the methamphetamine and opioid deaths, is different from the category that's in black. Now, the caveat is I do a lot of methamphetamine research. Seeing that steep curve is really good for my grant applications, but I think that steep curve is kind of cheating because most of that gray is fundamentally fentanyl deaths, and methamphetamine is more riding along rather than causal in the death pathway. And I want to give a few reasons why I think that. First off, there is no upper downer toxidrome. Nobody has ever shown up in an emergency department, not breathing, non-responsive, and freaking out. It has never happened. So there is an upper toxidrome and there's a downer toxidrome, to be very simplistic, but you can't have both at the same time. And in fact, methamphetamine raises the threshold for respiratory depression from opioids, including fentanyl. So, and we know also from decades of research prior to this that holds in post-operative settings, it holds in end-of-life care settings, it holds in multiple other settings. Stimulants, one of the reasons people use stimulants is so that they can more safely use more opioids. So if you had to decide, if you were forced to do fentanyl right now and you had no fentanyl tolerance and they said you can do it with this methamphetamine or without, you should probably do it with the methamphetamine because you'll be less likely to stop breathing. However, ongoing use of the two together is epidemiologically associated with higher rates of overdose, probably due to behavioral factors of ongoing stimulant use, as well as the fact that you learn that you can push that fentanyl dose higher and higher. And so you end up with more overdose risk combining the two together. But pharmacologically and mechanistically, methamphetamine does not appear to contribute to a fentanyl or other opioid overdose. The opioid stimulant deaths really fundamentally look much more like opioid deaths. These are data from San Francisco. For stimulant deaths, our median age of acute poisoning death from stimulants is 55. For opioids, it's 45. For the two together, it's 47. So it's much closer to the opioid number. And if you look at the additional causes of death that you see in these categories of deaths, so in that red-pink color is acute stimulant deaths, in the green is acute opioid and stimulant, and in the purplish is opioids alone. And you can see the opioids alone and the opioid and stimulants look really similar. They have the same amount of cardiac contributions, essentially an absence of cerebrovascular accidents, whereas you see a lot more of these other causes of death in the stimulant deaths that don't involve opioids. We started looking at things a little differently in San Francisco. We're now looking at all drug-related deaths. And part of the reason is because we're missing a whole bunch of deaths by only looking at acute events, acute poisoning events. We're missing almost all the alcohol deaths in pink, 94% of alcohol deaths. We're missing 30% of stimulant deaths. The opioids without stimulants and the opioids with stimulants are very similar. Almost all of those deaths are attributed to acute poisoning. Whereas the stimulants, only 70% are, and I would argue that many of those attributed to acute toxicity wouldn't be attributed to acute stimulant poisoning. They would be attributed to chronic stimulant use if they had occurred in a different setting. I want to give you an example of this. So for stimulant, we looked at where deaths occurred for our acute stimulant deaths. And what we saw was that in the community, the community deaths are in the purplish color, and vast majority of community deaths were determined to be acute. Whereas for deaths occurring in the hospital, only half were attributed to acute poisoning. And I think a big reason why you see more deaths occurring in the hospital not attributed to acute poisoning, they're attributed to other causes of death, is because the providers in that setting have telemetry monitoring, lab data, they have diagnostic capabilities where they're able to attribute the death to the real cause, which is usually something like congestive heart failure, some long-term cardiovascular toxicity, as opposed to a medical examiner who only has the death scene the medical record, if they can find it, the toxicology data, and the autopsy data. And you think maybe the autopsy data is going to tell it. If the person had a massive heart attack, you can see ischemic tissue on the heart. But if the person had a QTC of 500 and went into torsades with a fatal ventricular arrhythmia, their heart doesn't look any different than the heart that didn't have an arrhythmia. You can't identify fatal ventricular arrhythmias on autopsy unless you got really lucky with some ischemic heart tissue. So most of the time, the medical examiner has very little data to go on. And oftentimes the bodies have frankly decayed, and there are even fewer data to develop a diagnosis. And all you really have is the fact that they died and they had methamphetamine in their bloodstream. We're doing a fascinating psychological autopsy study in San Francisco, and this is one of the cases that we reviewed of a acute methamphetamine poisoning death for an individual who was 56 years of age, and he came from San Francisco. He was bisexual, estranged from his family. So his found family in San Francisco really became his home and his family. And his friend, and they pretty much all used methamphetamine. He contracted HIV, his friends aged out of use, or many of them passed away. He developed congestive heart failure and COPD. He got so sick he couldn't make it down the hall in his SRO to visit a friend. And then after not being seen for a week, his partially decomposed body was found in the room and was positive for methamphetamine. And thus it was declared an acute methamphetamine poisoning death. And to me, this death sounds a lot more like an aging elder who has no family to care for them anymore and whose friends have passed away, who's alone, who has multiple comorbidities, and they don't have the support, and they end up being found deceased in their home. So the intervention isn't naloxone. It certainly is for fentanyl, but for stimulants, a reversal agent is unlikely to have a meaningful dent on this. Instead, we need to, I think, focus on use reduction and recognizing that all the studies that we've done, Steve and myself, have failed to detect use reduction. We're detecting periods of abstinence with qualitative urines. So, we need to figure out how to fix our pharmacotherapy trials so that we can actually detect reduced use. We need to think about stimulants with a chronic disease model that's frankly closer to thinking about alcohol than it is to opioids. I think we've done a grave disservice, and I'm part of that because I've been working on overdose for 25 years, 30 years, and I'm one of the people who shoved methamphetamine and cocaine into the opioid overdose rubric. And I think that was a devastating mistake because our models need to be more about chronic disease. And frankly, for many people, it's more of an elder care model than it is an overdose prevention model that we should be deploying for these drugs. So let me actually ask one of the fellows, how would you, if you had somebody come into your clinic who used methamphetamine, how would you first approach them?
You mean just brand new patient, you're meeting them for the first time?
Yeah. What's the first thing you do?
Introduce myself, try to establish some kind of rapport. Because I know what we're getting to talk to about. They may not have been able to have the space to talk to a lot of people about. So I want to make them feel comfortable first and foremost. And then I'll probably be a little curious, like what brought them into sitting into my clinic? It wasn't easy to schedule that appointment, come all the way down, suffer in traffic, find a parking spot. And just let them talk, figure out where they're at and what they want to address first.
Perfect.
Absolutely. Sorry, I'm one of the other fellows. I will echo what Dr. Wang mentioned. Exactly asking like what is his knowledge about the methamphetamines, the use, what has he done about that before, any treatments. So I will add that as well.
So I love it. And I want to suggest explicitly addressing methamphetamine use with what I'm going to call a 4-tiered approach, and we'll go into what each one of these are. But the first is your general approach, which you've already started to describe. The second is the general preventive strategies that you're going to utilize that probably most people who use drugs should be offered. The third is reducing use. And the fourth, which I don't think we've really historically done, is trying to address and hopefully even prevent toxicities related to long-term exposure to these drugs. So our first case is a 45-year-old cisgender man living with HIV. It's been poorly controlled until recently, and he's been using methamphetamine every day for 35 years. He's also been smoking a half a pack a day for 40 years. He has no other substance use going on. And how would you approach him? How would you start to address his use? Any thoughts? I'm giving some hints here.
I guess I would start with does he want to talk about it? Does he have would it be okay if we spoke about it? Does he think it's a problem we should be addressing today?
Yeah.
Or maybe it's not the highest on his list of things he wants to go through today, and that's also okay. Hopefully we have a longitudinal relationship with this man and we can continue to discuss things.
Great. So I will tell you with this particular individual, I have a HIV clinic, and he was a new patient for me in the HIV clinic, and I ran through his HIV history and his issues, but I think of my HIV clinic as frankly more of an addiction clinic. And so I brought up his methamphetamine use, and I asked him, what did he get out of it? That's how I usually start. I made a mistake once a few years ago when I tried to treat someone for several years for their methamphetamine use, and then finally asked them what downsides they saw to their methamphetamine use. And it was a big fat 0. They saw no downsides at all. And I finally realized I had been spinning my wheels for years and wasting their time. So I always start by asking, what do you get out of it? And methamphetamine in particular, I think, has a lot of helpful effects for many patients. Whether it's staying alive on the street, tolerating sex work that they have to do for income, driving a truck, whatever it is, there's a lot of functionality benefits that people may get out of their methamphetamine use, and they might not really recognize risks. And the nice thing about asking about the benefits and risks is it walks you right through your DSM-5 diagnosis. With this particular individual, turns out he uses mostly in the mornings, sometimes in the evenings with friends. He never goes on runs. He sleeps regularly. He never does these 72-hour runs. He's usually got a job, and he stops when he needs to pass a urine screen without any problem, no tolerance, no withdrawal. He's not interested in addressing his use. He does have rotten teeth, which he attributes to his methamphetamine. So he has one DSM-5 criterion. So he doesn't have a use disorder. So what do you do next? Giovanni, you want to offer up?
Yeah, I will try probably to do a more like a comprehensive assessment in terms of like cardiovascular disease and pulmonary disease, of course, because it sounds actually one of the patients that I had to been using for 15 years, and he has a stable job and no issues until like suddenly he ended up hospitalized because he never had this screening about like cardiovascular disease or anything like that. And per patient, he was okay, but he wasn't. So he didn't know that he had like issues with his lungs, his heart, and because he never visited a doctor, he had a stable job and all of that. So I will probably inquire more about like other symptoms, stability, home, jobs, like pretty much all of that.
Great. So he doesn't have any. Oh, sorry, go ahead.
I was going to say we have a hand raised. I wonder if Sean also wanted to jump in.
Sean? All right, well, you jump in whenever you want to, Sean. I will tell you, he has no cardiovascular disease, no pulmonary disease, no psychiatric disease. He's actually, relatively healthy given the circumstances. So my next step with him I very explicitly say I want to talk about your methamphetamine use, and I'm going to talk about it in 4 buckets. And we're going to go through each one of these buckets. So the preventive strategies. Fortunately, I'm in an HIV clinic, and we do almost all of this already automatically. We have all our screenings, we have all our vaccinations, we have, we're treating HIV, we're giving doxy-pep, we have social workers, we assign in-house psychiatrists, in these Ryan White clinics. We've got all these resources. So we're able to provide most of this. The 2 things that aren't automatic are naloxone, fentanyl test strips, which we should be giving to anyone who accesses street drugs, particularly naloxone. Fentanyl test strips are a little more hit and miss, but if you have access to them, I recommend it. The 3rd thing that I do is I say, if you become interested in cutting back on your use, there are some things that I can offer to support you. Contingency management and a few different medications, and we'll talk about some of the medications. The novel piece that I bring in here is talking about addressing toxicities. So for this individual who has a job, he's cognitively healthy, he's cardiovascularly healthy, he wants to continue working and being active in society. Addressing toxicities becomes really important, and not just treating them because he doesn't have them yet, but actually trying to prevent them. So for treatment, the biggest message for cardiovascular disease and treating cardiovascular disease in people who use methamphetamine is not to be afraid of beta blockers. The data don't show this 1970s hypothesis of unopposed alpha stimulation for cocaine use that has been disproven repeatedly. But it is, but it still sticks. If you are scared of beta blockers, or your setting is scared of beta blockers, go with carvedilol or labetalol. They should avoid that disproven hypothetical concern. For neuropsychiatric treatment, generally we're talking about chronic, we're talking about atypical antipsychotics, and you're kind of picking them based on the patient. For more acute treatment, there's been a lot of luck with droperidol, which hasn't been in very wide use, but the ERs that have started using it again have had a lot of success with that. It's, I think, really fascinating. For this particular patient, when I was on the prevention side. So I'm thinking about smoking cessation. Is there a role for statins? Is there a role for aspirin, SGLT2 inhibitors? Who knows? N-acetylcysteine, et cetera. He sleeps every night. So that's probably part of the reason he doesn't have a psychosis, and part of the reason he has good cardiovascular health. Those of us who have gone through medical training, we all know that not sleeping for 30 hours every 4th day cut a few months to a few years off of our lives. So it's going to do the same thing for somebody using methamphetamine. So, and I'll go a bit into the statins, but this particular individual, not interested in reducing use, but he got really engaged around the discussion of toxicities, and he was like, absolutely 100%, I'll take a statin. Yeah, no question, I want it now. And so he, let me talk a little bit about statins, because I think, let me ask the fellows again, do you prescribe a statin to patients who use stimulants?
I'll admit it's not one of the things I think of unless I'm already checking their cholesterol for something else, so they have it for another reason. But maybe it should be.
Yeah, we're starting to incorporate that more into our clinics.
All right. So the toxicity of methamphetamine is inflammatory and also mitochondrial mediated. We have really good data. We have increasingly good data out there that statins reduce cardiovascular events among people who don't have an indication for statins, both HIV positive and HIV negative. With this Reprieve study, probably the biggest, hottest one recently that was in New England Journal of Medicine last year, with really remarkable reduction in major cardiovascular events and mortality for people with HIV. I will note they don't have the granularity of substance use data in that study that I would like, but the majority of people did use cocaine or methamphetamine in that study. So I love my HIV colleagues, and I think that a lot of the cardiac disease attributed to HIV is might be better attributed to substance use if there was more granular substance use data in some of those studies. Dapagliflozin, of course, an SGLT2, does prevent meth-induced cardiomyopathy, at least in a mice model. I hesitate on SGLT2 inhibitors for people who use methamphetamine because of the ketosis issue, and I don't know if there might be a higher risk there that may not be worth the hypothetical benefits. On the neuropsych side, there's actually a lot of data out there that statins reduce in the general population, statins can reverse some of the cognitive dysfunction in dementia. They slow the onset of Parkinson's disease. And in animal models, they can prevent the onset of Parkinsonian symptoms in rats induced by methamphetamine. They can reduce this decrements in spatial learning and memory in rats. They reduce the cytotoxicity of methamphetamine. And they also reduce, at least for cocaine, hasn't been tested in methamphetamine, the thrombotic effects of cocaine. So there are actually reasons to think we might be able to prevent, or heck, maybe even slightly reverse, some of the neuropsych toxicities we're seeing with methamphetamine with a statin. So yeah, this isn't the level of data a cardiologist wants to start using a new drug. This isn't the level of data an HIV care usually works with. This is the level of data we get with the pennies on the dollar of funding that addiction gets. We're never going to get a 10,000 person study showing that methamphetamine reduces cardiovascular events among, statins reduce cardiovascular events among people who use methamphetamine. It's not going to happen. But there's enough mechanistic reasons and I think a low enough risk profile that I have started doing it.
About that, do you have a preference for which statin we'd use or what dose you go for?
So in general, I've gone with atorvastatin because I'm so comfortable with it. I've used it for so long, and it's the drug used in most of the studies, and it has good CNS penetration. So for those reasons, I've tended towards atorvastatin. If I'm in an HIV clinic, so sometimes pitavastatin is the way I have to go.
And what about you?
The next question is dose. Like what dose?
Yeah, dose. Yeah.
Yeah. I mean, I'm going to lean towards a lower dose. I don't have anything magic. I would go with 10 or 20 milligrams of atorvastatin, just because I don't want to. I want to limit potential toxicity. Another thing I've thought about, and which I am doing for at least one patient, is checking a CK beforehand. Just because sometimes people with methamphetamine who use methamphetamine live with a CK of 300 or 400 because they're using all the time and they're burning some muscle mass. And even if you're going to give them a statin, you want to know that that CK elevation wasn't from your medication. It was their baseline. I'll throw another thing in here, which I haven't done yet, but a talk I gave 2 weeks ago, one of the syringe access program attendees of the talk suggested it, and I'm going to start doing it, I think. And that is, I'm going to start sending, when I start treating people for methamphetamine use disorder, I'm going to, before treatment and at the end and during treatment, I'm going to send some cardiovascular biomarkers like high sensitivity C-reactive protein. And if I can document a reduction, even if their urine's still positive, if they say they're using a quarter as much, and I can see that they have less cardiovascular inflammation, I think that could be really positive feedback for them. Again, I haven't done that yet. It's on my agenda for the next patient. So this particular individual, he returns a month later and he says, "Doc, I started taking the statin. It's going great. But I was thinking like, I want to reduce the toxicity of as much as possible. So I should probably reduce how much I'm using. Right?" And I'm like, "Yeah, you probably should." And so he says, "You mentioned some meds that could help me out." I'm like, "Yeah, sure." And so he ends up starting on bupropion. And I schedule him for 6 months out. He comes in 4 weeks, every 4 weeks, to tell me all about his substance use. And he has dropped to using meth once every week or two and smoking usually 0, sometimes 1, never more than 2 cigarettes in a day. This was a shocking and unexpected success for me. I'm going to go on to another case. This will be a shorter one. This is a 33-year-old man living with HIV. He uses meth pretty much every day, often on runs for 3 or 4 days. He's been to psychiatric emergency services on 5150 twice in the past year, but he only has psychotic symptoms when he goes on runs. He doesn't have any symptoms of psychosis, and the psychiatrist PES doesn't think he should be on a standing antipsychotic. So what can you do for him? Any ideas? Remeron.
Yeah.
I see that. I see that listed. Mirtazapine would be one of my favorite drugs.
Definitely, I will do a more also comprehensive psychiatric history, because want to make sure that this patient doesn't have any other additional comorbidity, major depressive disorder, bipolar disorder, something on that realm.
Great. So I'm going to use this as an opportunity to suggest a really novel intervention that we just started doing about a year and a half ago at San Francisco General Psych Emergency Services. We're calling it the Chill Pack. And that is people who come into psych emergency services with meth psychosis. Most of them were on a 5150, I think it was 85%. We gave them a little kit with 4 olanzapine 5 milligram tabs and instructions to use them when meth got a little too crazy for them, with the hopes that they would use it to come down when they were too high, to avoid getting in, altercations, to avoid landing back in psych emergency services on a 5150, etc. Our study of this with 92 people, the 92 first recipients, 2 months prior, they had just over 2 PES visits. And in the 2 months after getting the Chill Pack, they had 1.44 PES visits. So this is very early, very preliminary. It could be spurious, but it's compelling, and it's a totally novel concept that goes against a lot of sort of psychiatry training of not using antipsychotics unless somebody has a standing psychotic issue. Olanzapine was picked, as asked in the chat, because it has the fewest drug interactions of the classic atypicals, which would be aripiprazole, risperidone, and olanzapine. Any questions about that? And we tried to use the solutabs as they're easier to tolerate.
So the directions that you would give the patients, or it's really just patient directed when they feel like they're getting out of control.
Yeah.
That's when you would take a medication.
If they're seeing things, if they're feeling paranoid, if they are feeling out of control. We also, what we figure happens, we don't know yet how they actually used it or if they actually used it. But my suspicion is that it may have gotten used a lot to come down from a high. And even if it was used instead of a pill bought on the street, that's another opportunity of them to avoid a fentanyl exposure with a pretty safe drug. The other reason we picked olanzapine is because it has no street value. It's not as sedating as olanzapine is fantastic sleep, it says in the chat, but it's not as sedating as Seroquel. It doesn't have the street value there. Okay, 30-year-old cisgender man using methamphetamine a few times a week at night, goes on runs, but just 1 to 2 days. He has no other substance use. He's pretty skinny. He has no cardiovascular or psychiatric issues. And he wants to stop using. And he went to inpatient rehab like 3 times, but it didn't do anything. What are you going to do for him? Any ideas? Where would you start?
Ask him what methamphetamine does for him. Kind of taking note from your lab.
Yeah, that's great. That's great. Um, I'm going to move us to the use reduction side of things. Jessica posted find a contingency management program. Hooray! We have them in California. Yeah, so contingency management is fantastic. I do want to use this case as an opportunity to talk about the pharmacotherapies. ASAM guidelines came out, and this is the list of therapies that we have per the ASAM guidelines. I think the top ones are the better options of mirtazapine, bupropion, naltrexone. Combinations of those 3 drugs are probably where things are best at this point in time. For mirtazapine, these were the studies done in my shop in San Francisco. We're seeing something akin to a 1/3 reduction in use. Adherence is not stellar. But we see the reductions in use even with poor adherence. It's got a long half-life. So does it help? Yeah. And in my clinical practice, I find that it helps, especially it helps for the motivated people. You've got the people who would only thrive on an injectable because they're never going to be motivated to take a pill every day. And that makes this regimen less effective, I think, unless you have a way to do video directly observed treatment and incentivize adherence. The induction I was asked about, yes, start on 15 milligrams for a week and then go to 30. I really shy away from going over 30 unless somebody has a very low BMI because of the almost guaranteed weight gain. 30 milligrams, most people don't put on much weight. You go to 45 milligrams, everyone puts on 20 pounds. So in this particular patient, he gets up to 30 milligrams and he cuts down his use into about twice a month. He relapses about twice a month. And that happens after he goes out drinking with friends. So he goes out around, 10, 11 o'clock. He's drinking with friends. 1 o'clock rolls around. They go home. They go back to his place, smoke some meth, and then he ends up on a run until 1 a.m. a day later. And he is really frustrated with these relapses. What do you want to do now? Naltrexone extended release. I love it. That's a great idea. In this case, what I did was oral naltrexone, in part because he's a really motivated person, and he really, really wants to cut his use, and he's already stably taking a pill a day, so not too hard to take another. And he tolerates it. He does well, and he goes and it cuts down to the point where he relapses like once every 2 or 3 months. He's still frustrated with that. He still wants to go up to 45 milligrams of mirtazapine. So that's an example of sort of combining medications. I know psychiatrists combine mirtazapine and bupropion quite a bit for methamphetamine use disorder. As a non-psychiatrist, I don't. I still have that, decades-old fear of too many serotonergic agents on board. But psychiatrists tend to not be afraid of that and are quite comfortable combining the two. For myself, I hesitate a bit. So I want to show this and give credit to Aisha Appa, my mentee and professor and collaborator at UCSF, who we created this together. I really like it. The idea here is start with contingency management if you can. Everyone can benefit from contingency management if you have it available. If they have cardiac disease, which makes it hard to give bupropion because it is, we have some cardiovascular disease limitations there. And certainly if you're going to push up to that 450 milligram dose of bupropion, you want to know their QTC beforehand. If they want weight gain, or if maybe if they have depression, but depression, you can go either way. Mirtazapine would be my first line in those circumstances. If they are really interested in, if they, the methamphetamine wakes them up and helps them get through the day, and they would rather not use meth, but they need something to stay awake and get their stuff done, or if they are also smoking, then bupropion is a really good first choice, because it's sort of an agonist replacement therapy. One way, if you were going to combine the two, you might think about bupropion in the morning and mirtazapine at night, if you're going to go bold that way. So, and that bupropion, generally, I recommend 300 to 450 milligrams. So oftentimes people stop at 300. They're too jacked up at 300 and they don't want to push the dose higher. If you have somebody who is really engaged, wants an intensive treatment, and or they have comorbid alcohol use disorder, adding on IM naltrexone is a great addition, I think. And honestly, you can add it on to either therapy. There's no contraindication for mirtazapine, and my guess is you're going to see a similar benefit as we believe we saw in the ADAPT-2 trial. Oral naltrexone is a great option as well. And I think, part of the reason I picked oral in that last patient was because his relapses were intermittent. He didn't go out drinking all the time. His mirtazapine held him fine. And there are great studies out there. A colleague of mine, Milo Santos at UCSF, did a study in my shop showing the benefit of intermittent naltrexone for binge alcohol use. And it can be really effective for people to have that naltrexone on hand. And if they're going to be partying all weekend, they can take their naltrexone. If they're not, the injection's great, but if they can't, or they don't want that, or their concerns are more intermittent, or they're already taking pills every day, the oral can be a great option. From there, we go to really addiction medicine consults. Topiramate, the data are not good for topiramate. It's on the list. It's an option. I have one patient I'm planning on trying it in, and the long-acting stimulants, particularly sustained release methylphenidate, is the option there. That can be legally, it can be a little bit tricky. The federal law does not block you from using these for methamphetamine use disorder. However, some states might. So knowing your state law well is important, because state laws can be more restrictive on controlled substances for addiction. In general, if you're using it to treat ADHD and somebody who's also using methamphetamine, I don't believe there are any laws that would inhibit that in the country. Any evidence for 50 versus 100 milligrams of oral naltrexone? I've only seen 50 used. I get a little bit concerned with oral naltrexone and hepatic failure. There are some cases when you push the dose of oral naltrexone of liver issues that don't occur with injectable and don't really seem to occur with the 50 milligrams.
Dr. Coffin, to bring you back, I think there's a couple more questions. This is going back to the chill packs you were talking about. There's a question about what type of labs, if any, you think are important to have before giving the chill packs?
We don't do any labs. It's 4 pills of olanzapine. So the idea is that somebody's using this quite intermittently, and it should be well tolerated.
What about like QTC screening, anything like that?
A single 5 milligram dose, we're really not concerned.
Okay, cool. And then there's also a question, I guess we could, if now's a good time, we can answer just generic questions now too. The question says, a few years ago, we tried to use mirtazapine and bupropion in our jails for stimulant disorder and could not get it because it wasn't approved for this use. Do you think the new ASAM guidelines would serve for this?
I think that's great. Yeah, that's use the ASAM guidelines. That's what they were. The folks who made them wanted to make them so that they could be used by clinicians and so that we could expand the services. One of the things that helps make it legal to use methylphenidate for methamphetamine use disorder is the fact that it's in these guidelines. So, you know, you can do it if it's within standard care, and having it in guidelines helps to shift it towards standard care and relieve some of the concerns there. So the guidelines go a long way. Kudos to all the folks who worked on those.
And then we have one last question. We can keep it brief because I know the cocaine use disorder meds are a whole nother bucket, but which ones of these medications would also use for cocaine use?
Bupropion. The data are, there's some good data for bupropion for cocaine, and for the long-acting stimulants, modafinil is the one that has data for cocaine. Naltrexone is again mixed. Naltrexone's kind of mixed for stimulants. I don't think of it as a I wouldn't use naltrexone as a monotherapy for a stimulant use disorder unless I, for whatever reason, could not use anything else. But I think it's an effective add-on. There's another comment in the chat.
There's another question by Daniel Amaya. He mentioned, we as counselors, what can we do, or what is the best approach when the medical provider is not familiar with addiction medicine at a county level or homeless clinic due to the lack of services for undocumented Latino population?
So I want to recommend that there's a link on the bottom of this, that link to the article that me and Dr. Suen recently published on this particular model for managing methamphetamine use. I really want to encourage you to pull up this article. This link takes you to a full text version of the article, and pull it up, take that 4-tier approach and suggest, I feel like this 4-tier approach is really effective, and it really opens doors, and it allows patients to have a goal-directed therapy of their own. It gives providers a structure, because we've never had a structure for managing methamphetamine use. Diabetes was a disaster 60 years ago when we didn't have a structure. We have a great structure for managing diabetes. It's worked into all of our clinical care systems. Even opioid use disorder, we've got a structure by which we approach managing somebody who uses opioids. But for people who use stimulants, we've never had a structured approach. So this 4-tiered approach, I literally tell my patients, I'm going to approach your methamphetamine use from 4 pockets, tiers, whatever you want to call them. And I walk them through it. And to having that systematic approach, I think it's powerful for the provider, because then they can feel like they have something to do. And many of those things don't take advanced practice, knowledge, specialty knowledge. And it's powerful for the patient, because it allows them to kind of pick the interventions that they feel most inclined towards. I will stop sharing.
Right.
And I'm happy to take any other questions, or if there are other cases that you want to discuss.
I'm scouring the Q&A. I'm looking through everything. I think there's only one question we missed. I think going all the way back to when you were talking about benzodiazepines and treating like acute, I think it was acute psychiatric symptoms. The question along the lines of, can you talk about, where's the question? What is the risk for developing panic disorder, anxiety disorder when treating with benzodiazepines?
Treating just in general with benzodiazepines, or treating people who
So it's my question. I'll own up to it, Philip. So sometimes when people stop using methamphetamine, their anxiety goes through the roof. And so if you start using benzos, they can start to rely on the benzo, which feeds this cycle of iatrogenic panic and anxiety disorder. So I was just wondering, what are your thoughts about that?
Yeah, it's always a concern when people start using benzos. I agree with you. How to manage it?
Mirtazapine, right?
Yeah, exactly. You want,
Right.
I mean,
Yeah.
bupropion's not going to help with that because
No.
it's going to raise your anxiety level. So, yeah, I'm just thinking about what other medications can I offer and what, CBT do I have available to help them, cope with, cope with this change. Yeah. Yeah, I think contingency management plays a role, especially when there's groups associated with the CM, and so you have other people you can talk to. That might be a place where some of the group support programs might be helpful.
One last question. What about adjunct meds like clonidine or hydroxyzine, PRN?
Yeah, so these are good. There's any of these adjunctive medications can be helpful for somebody if they're experiencing withdrawal symptoms, if they, hydroxyzine can certainly be helpful for somebody to help them go to sleep or relax. So yeah, I use these things as needed.
And what about geriatrics? Older folks. We're getting a lot of older folks now, me included. So would you change? How would that alter your thinking here?
Yeah, it's a great question. As you get older, your heart disease increases. So your ability to tolerate of medications like bupropion is declining. And also your ability to tolerate ongoing methamphetamine use is declining. So it gets a little bit tricky. We always have to be more cautious with medications. Older people are more sensitive to lower doses of medications. So, maybe you want to start with 7.5 of mirtazapine and go up to 15. Maybe you want to start with a lower dose of bupropion if you're going to go there, keep it at 150 or something like that. Yeah, so that's generally my approach. And I agree, it's older and older, which on the one hand is challenging, but on the other hand, it means they didn't die.
One last question regarding possible screening for cardiovascular or pulmonary disease. Any recommendations or when to start screening for patients with chronic use of meth?
Great question. Again, I practice in a comprehensive HIV clinic, so I'm always screening for all of this stuff. But I haven't thought about it specifically for methamphetamine, except in terms of, let's say, biomarkers or something. What I've done, I've treated them like any other primary care patients to date. I get to see these patients on a regular basis, and I'm sending labs every 3 to 6 months anyway. So I'm effectively doing all this type of pretty intensive screening on people, even if they're 25, because they have HIV. So I'm in a little bit of a different domain, trying to transition my brain to non-HIV domain. How would I manage somebody who uses methamphetamine? When would I start thinking about it? Okay, so we are trying to develop a measure of cumulative methamphetamine exposure that I shall call a gram year history. We use it all the time for tobacco. We don't have it for meth. And yet we know that the toxicities from meth are probably a combination of cumulative exposure and binge use patterns, just like with alcohol. So if you were to ask your patients, how long have you used meth, about how much you use a day, and knowing that a gram, at least in San Francisco, is about $10. So if they use $10 a day and they've been using for 20 days, they've got a 20-gram year history. And you can kind of eyeball that in your head and say, okay, that's a fair amount of methamphetamine exposure. They've probably got significant risk for toxicity. If they're 25 and they've been using for 6 months, I'm not really worried yet. So I do not have a specific measure yet, but it's a place I want to get to.
We have one more question, but we're already at time. So I think what we'll do, I'll ask if you want to go out on a question, you can riff on that, or I know Dami has some details here that she has to tell us about. So you want to hear the question? So are there any differences in your approach to patients who have pure stimulant methamphetamine use disorder versus those who have co-occurring OUD?
Yeah, I mean, frankly, I'm more concerned about the OUD in most circumstances, and our medications, our therapies are more powerful in that domain. So that's usually my primary focus, and the stimulant comes after, and that's usually where patients want to go as well. So that usually aligns. And oftentimes their stimulant use may be to mitigate the oversedating effects of fentanyl if that's their opioid of choice. So you're not going to get, you got to get there, you got to target the opioid use first. In terms of medications, there's some data that buprenorphine might help a little bit with methamphetamine use. So that's definitely my first goal is to try buprenorphine. I'll stop there.
Well, thank you, Dr. Coffin. Thank you all for this engaging discussion. And if you have any questions, feel free to put in the chat. I'll leave the chat on for a little bit. And then we can ask Dr. Coffin to respond to it offline and send it via email. So thank you again for taking the time to present this important topic to us. And thank you all for being in attendance.